All right, welcome back. Today we're going to talk about the usage of pulse oximetry and near-infrared spectroscopy for monitoring in the pediatric intensive care unit. So just a bit of history. Pulse oximetry was invented in about 1974 and was only really able to be used commercially in the 1980s due to the advancement of computer processors. Prior to pulse ox, reliance upon physical exam and ABGs was the only way that really had to measure blood oxygenation levels. So pulse oximetry has represented a significant advancement in the ability to monitor patients in real time and monitor their oxygenation levels. So these are just two different types of pulse oximeter monitors that we have. The first type is known as a transmission type, and essentially it functions by having two LEDs which emit two unique spectrums of light through a body part, which is highly vascularized, and the light that passes through the body part is absorbed or taken in by a photodiode, which analyzes it and is able to give us information regarding the oxygen content of that blood. On the other hand, there's a type of pulse oximeter known as a reflectance type, where the LEDs are reflected into a body part, and then whatever light is reflected back to a photodiode on the same surface is analyzed to determine the oxygenation level of the blood passing nearby. So the principle of pulse oximetry, or how it works, is that oxyhemoglobin, red blood, and deoxyhemoglobin, aka blue blood, have different light absorption characteristics. And so the pulse oximeter essentially will shine light at two different specially chosen wavelengths into highly vascular tissue, and then will detect changes in either the transmitted or reflected light in order to determine the oxygen content of the hemoglobin in that blood. So this depends upon a pair of laws, which together are known as Beer-Lambert's law, and they describe the characteristics of light passing through a substance. And so in summary, the amount of light that passes through a liquid substance in this case is proportional to the concentration of the liquid and the distance traveled. So as you might imagine, light passing through a column of liquid that is more highly concentrated is less able to make it through that column of liquid. And additionally, light passing through a wider column of fluid is less able to pass through than passing through a narrow column of fluid, as you can kind of see in this cartoon. So here's another cartoon demonstrating the schematic or the principle of pulse oximetry. You can see that you have the LEDs emitting light from the top of the picture and then a photodiode below, and only some of the light is making through. And this cartoon also does a nice job of demonstrating the pulsatile nature of the blood flow and how that's analyzed by our pulse oximeter. So you can see on this graph down here at the bottom, which shows time versus absorption, that with time, there's different amounts of absorption of light as the pulse is happening. As if you listen to our earlier lecture on arterial waveforms, you'll remember that the pulse is a waveform that goes up and down in amplitude with each heartbeat. And so this information is captured by the pulse oximeter and analyzed, and actually gives us good information about the relative proportions of arterial blood versus venous blood, because as you may know, arterial blood is flowing in a more pulsatile waveform than more static and linear venous flow. So we spoke about the two distinct wavelengths of light that are used in a pulse oximeter. And these two wavelengths of light were chosen because they're able to well discriminate between oxyhemoglobin and deoxyhemoglobin. And so what I mean by that is the fact that these two wavelengths chosen were red and infrared wavelengths of light at approximately 700 and 900 nanometers wavelength. And so you can see red light, which is approximately 700 nanometers wavelength, is more absorbed by deoxyhemoglobin. That's why it looks blue to us. It doesn't look red, right? On the other hand, infrared light is more absorbed by oxyhemoglobin. So these are opposite from each other. So because you have that scenario, you can see that these wavelengths of light absorb different levels of, are differently absorbed by different types of hemoglobin. You can discriminate and determine the relative proportions of how much oxyhemoglobin versus how much deoxyhemoglobin there is in the blood that is sampled or analyzed. So there are some limitations to the use of pulse oximetry, and briefly, those are the calibration of our instruments, the issue of skin pigmentation, the fact that not only is there oxy and deoxyhemoglobin, but there are other hemoglobins present in our blood, and then the issue of skin perfusion and the data that we're getting from the patient. So first, calibration. Essentially, with the invention of pulse oximetry, the creators were doing a very clever thing, and they were correlating ABG partial pressures of oxygen with their new pulse oximetry values. And they basically were trying to determine, what PaO2, what partial pressure of oxygen on an arterial blood gas would correlate with what pulse oximetry readings. And that's how they calibrated their instruments. However, as you might imagine, there were some ethical concerns regarding getting some lower oxygen saturation levels, particularly in healthy research subjects. So what they were able to do in this study, in the origin of designing pulse oximetry, is they were able to desaturate these patients, but only to a certain degree. They were only be able to really get pulse ox readings that were down to about 80%. And due to ethical concerns, they were not able to really push the envelope beyond that. So we know that pulse oximetry readings are based upon directly measured information to sats down to about 80%. However, any sats below that are really just extrapolated from that information that we have. So unfortunately, pulse ox values that are below 80% are not necessarily truly reflective of what we're seeing in the bloodstream, because they are based on extrapolated values. And so we have to be a bit skeptical of the accuracy of pulse oximeters as they go below 80%. And additionally, the study population was not necessarily representative of the population at whole and the population that we care for in our pediatric ICUs. And so what I mean by that is different degrees of skin pigmentation have different characteristics when it comes to light absorption. And it's well studied now that melanin absorbs many wavelengths of light. And so there are concerns regarding the calibration of these pulse oximeters, especially older models on study subjects that didn't necessarily represent the population at large. So some patients have a lot of melanin in their tissues and some have very little melanin in their tissues. And so there's been an interesting body of literature that emerged, particularly during the COVID-19 pandemic, that patients with darker skin tones and higher levels of melanin may actually have more occult hypoxemia because of the way that their skin interacts with the wavelengths of light from the pulse oximeter. So that's a very interesting and very important thing to recognize, that some degree of hypoxemia may be under-recognized in certain populations because of the instruments we're using, because of the wavelengths of light that are being absorbed. Additionally, and particularly pertinent to pediatrics, is that jaundice also affects light absorption. And so, as you can probably imagine, babies that are yellow or orange from high levels of jaundice, that may affect their pulse oximeter readings as well. So that's an important thing to keep in mind. So in the works, there are some companies that are trying to design a better pulse oximeter and using different wavelengths of light, such as green, and those are still to be unveiled. But hopefully, that will help with the issues we see surrounding skin pigmentation. Other limitations is that, as I alluded to earlier, there are other types of hemoglobin that are analyzed by our pulse oximeter, and not just oxy and deoxyhemoglobin. And the two probably most famous examples are the presence of carboxyhemoglobin and carbon monoxide toxicity, and methemoglobin in conditions such as G6PD deficiency or under a burden of high oxidative stress. So examples of this are things like inhaled nitric oxide or the administration of respiricase, among other medications. And so this is just another cartoon which shows how different types of hemoglobin react or behave with the absorption of different wavelengths of light, those wavelengths that we talked about before. So you can see where that big arrow is on the left, on the red column, that carboxyhemoglobin has strikingly similar absorption characteristics to oxyhemoglobin at the red wavelength of light. And so it's for this reason that often if you have carboxyhemoglobin or you have carbon monoxide toxicity, you may see bright cherry red blood clinically, and you may see very high pulse oximetry readings on a pulse ox. However, the patient is not really getting oxygen delivery to their tissues, and the machine is being somewhat fooled by the absorption characteristics of carboxyhemoglobin versus oxyhemoglobin. Additionally, methemoglobin can trick you as well. You can also see that there's an overlap between methemoglobin and deoxyhemoglobin at this point here. And so that also can fool you and make you think that your oxygen saturation is somewhere in the mid-80s when you actually have a significant burden of methemoglobin in your bloodstream. So additionally, pulse oximetry is somewhat limited by the fact that it needs good skin perfusion to perform well. And unfortunately for us, skin perfusion is usually declining simultaneously with blood oxygen levels. And this occurs all the time in conditions such as hypovolemia or shock or vasoconstriction, where your body is triaging and getting blood to where it needs to go most and often shunting it away from peripheral skin and vascular beds. So this means that pulse oximetry is usually less accurate when you need it the most. So with that, we move along to near-infrared spectroscopy, also known as NIRS. And so this is a similar technology to the pulse oximeter. It also was first used or invented in the 1970s and uses a similar band of infrared light, near-infrared light, to analyze the oxygen content of our bloodstreams. And it also operates on Beer-Lambert's law principles. But the difference between pulse oximetry and near-infrared spectroscopy is that it is actually, NIRS is trying to sample a mixture of small vessels in the peripheral skin and the superficial layers of our tissues. And that includes arterioles and capillaries and venules. And so as opposed to just trying to determine a pure arterial oxygen content, NIRS is actually more analogous to a regional central venous oxygen saturation. That is, it's looking at kind of how much oxygen is delivered and how much oxygen is extracted. And so it's really a nice measure of regional oxygen balance, which is valuable and distinct information from what we get from a pulse ox. So this is just a cartoon demonstrating how a NIRS looks when it's applied to the brain. And this is one major type of near-infrared spectroscopy that we use. You can see there's a LED light emitter and then two photodiodes at different distances from that. And so this light is transmitted and then absorbed when it reflects off of these tissues and these vascular beds. So the burning question is always like, well, what are these numbers meaning and how do we interpret them? And so normal values, I will say, do vary by patient and by equipment. Upon literature review, it was found that these are determined to be kind of in the neighborhood of normal cerebral mean values for children, in the mid-60s and perhaps a bit lower for infants. And then for renal or somatic NIRS, or they're sometimes called, these mean values are a bit higher in the 70s or 80s. And so the reason for this is because, as you know, the brain is a highly metabolic organ. It requires a large amount of oxygen. And so the amount of oxygen extracted from the vascular beds around the brain is significantly higher than the amount of oxygen extracted from tissues in the thorax or in the quote unquote renal area. And so for that, because of that, we can actually look at this pattern of differentiation between the cerebral and the somatic or renal NIRS to determine how a patient is doing. And so what I mean by that is you can look at a patient that's healthy in the first row, and you can see that perhaps their cerebral NIRS are somewhere in the 60s, and their renal NIRS typically will be in the 80s. However, if you have a patient that's an extremist that has decreased oxygen delivery or increased oxygen extraction, they may be able to maintain their cerebral NIRS in the 60s still, but you may start to see some decrease of decrement in the renal or somatic NIRS. And that's probably because, the brain being a high priority organ, we see that the body is preferentially preserving oxygen delivery to the brain, but shunting away from perhaps quote unquote less important vascular beds, such as the superficial layers of the back around the kidneys and in the thorax. So you can start to see this decrement or this differential between healthy renal NIRS and stressed renal NIRS, while the cerebral NIRS are somewhat preserved, at least in the early stages of a patient decompensating. Now, is there like a critical value or a hypoxic ischemic threshold that demonstrates, that our oxygen levels are below a dangerous point? And there is some interesting piglet data done from studies on piglets out there that showed that at about 44% cerebral, or rather cerebral NIRS, there was increased brain lactate levels. Slightly lower than that, you started to see decrease in amplitude and then slowing of EEG brainwaves. And then at about 33%, you start to see decreased tissue levels of ATP. So these seem to be around the critical threshold where we start to see damage or hypoxia and loss of aerobic metabolism in our cerebral tissues. So based on this information, a practical approach could be adopted that, approaching this patient that has a renal NIRS or a cerebral NIRS of about 60 to 80% is about normal. And so that really just means, as we think about mixed venous or central venous saturations, that you're delivering usually 100% saturated blood, hopefully, God willing, if you're lungs and your heart are delivering enough oxygen. And then normally under normal circumstances, returning anywhere in the 75% saturated blood neighborhood. But if you do have decreasing cerebral NIRS and or levels less than 60%, that certainly warrants evaluation. And additionally, a lot of people rely more on the trend than the absolute values. And so, having this over a timeline can be very valuable information, as you can watch this from minute to minute and hour to hour, more than just the absolute values. But that being said, if you do have worries that you're having declining NIRS or you're having an absolute low number in your NIRS values, you can think about ways to either increase oxygen delivery. That can be increasing your fraction of expired oxygen, excluding hypocapnia in cerebral NIRS, especially giving fluid or vasoactive support, or correcting for anemia. You can also think about ways in cerebral NIRS decline to decrease oxygen extraction. So you can increase sedation for a patient, treat fever, perhaps think about, is there seizure activity or subclinical seizures? And then always in cerebral NIRS, if there's an abrupt change, you need to think about assessing for or treating intracranial pathology, such as an increased intracranial pressure. So NIRS, because of their utility, they have actually been found to improve outcomes, particularly those patients undergoing cardiac surgery with cardiopulmonary bypass. And the main reason is they're really good at timely identification of any aortic cannula malposition or inadequate pump flow. So if that aortic cannula is somehow impeding cerebral blood flow, that's something that's difficult to recognize without the cerebral NIRS technology. And so seeing that value in real time and being able to trend that is very valuable, particularly when you have, a small margin of error for these tiny cannulas and tiny babies, and you want to maintain good cerebral perfusion in order to protect the patient. Right now, there's really a lack of high quality evidence regarding other usages of NIRS, but hopefully there are some RCTs coming to support their usage, as they're already widely adopted. So in summary, NIRS, along with the other modalities we spoke about, including arterial lines and central venous lines, are valuable monitoring tools, and they offer different layers of information. And when used interpreted properly, they can provide great information to take care of your patient. So thanks for your viewership, and we hope to see you back here soon.